I actually did 2 years of psychiatry at Duke University and found that I liked psychiatry but liked radiology much more, so I changed to radiology as a specialty. And then I did my fellowship at UT Southwestern in Texas. Did 4 years of radiology, general radiology, and then really loved breast imaging. And the reason for that is that we do a lot of imaging, we do biopsies, but we also see patients, so the patients see you as a doctor. So I think it played with well to my personality. I think I get along with patients very well. And so I did a fellowship in breast imaging, which is a year long. So that specializes in screening, diagnosis, and treatment of breast cancer. So I am a breast specialist. I've been doing this for 20 years. One of the things that's different from a general radiologist in breast radiologists is that we really are clinicians, that I know about your symptoms, whether your discharge is concerning based on the history that you give me. I do physical exams on my patients so that I actually feel the lump that they feel. And a lot of times it's normal tissue, but sometimes it's a mass. So I have a lot of information, not just the pictures, but also the physical examination, talking with the patient, evaluating the symptoms. So I think that our diagnoses are more accurate just because we have more information. And so that's a question that a lot of women have. So screening mammograms are for women who don't have any symptoms. So for average risk women who have no family history or other risk factors, that starts at age 40. And so those patients are patients who don't have any physical symptoms themselves. They don't feel a lump, they don't have any abnormalities that they can detect. Their physician doesn't feel anything abnormal. And we're just looking to see if we can find things that you can't feel. And so that's the real purpose of screening mammography, is to find things that are very small so that we can find them before it would be palpable, hopefully making that diagnosis early so that it's treatable, hopefully curable. Patients who are diagnostic, it really is a problem-solving evaluation. There's something specific that we're trying to evaluate. Either she has a lump, she has discharge, she has thickening, she has focal pain, she has discharge, some particular finding that she has that is not normal for her. And so we would do the mammogram as the first line in most patients, and then we would generally follow with ultrasound to give them a diagnosis as to whether this is concerning or not. At the diagnostic evaluation, we could tell, say you have a lump and it's a cyst on the ultrasound. It's benign, we're done. So she's happy, yes, she has a lump, but it's a benign lump. Or she could have a lump and it looks concerning, or we can't tell that it's a benign lesion, then we may recommend ultrasound. One of the things that we do here is that for all diagnostic patients, we talk with them at the time of their evaluation so they know their results before they go. So I get to explain to them what I see and why I'm recommending what I'm recommending. If it's that I'm recommending that they go back to annual screening, I tell them why. This is not a cancer, it doesn't have any risk for cancer. Or if it's something that it needs to be biopsied, I let them know why and explain the procedure to them. So I think patients like it a lot just because they're not having to wait to get their report. And they get to ask me, the person that is making the decision about that, questions about what we see and why we're doing what we're doing. I came from Phoenix, Scottsdale area, and there are a lot of breast radiologists in the valley. And I think that the service that is there, the women in northern Arizona deserve the same type of service. And so I think I give a different level of service than what they've had before. Probably the only other thing that people ask me about a lot is the radiation dose for mammography, because there are some people who don't get their mammogram because they think the radiation is going to cause cancer. And the amount of radiation that you get from a mammogram is pretty minuscule, and I equate it to the amount of radiation that you get when you're flying in a plane. Because you're at 30,000 feet, you have atmospheric radiation, so it is a very similar dosing of radiation. So I tell patients I would not defer a trip to Paris because of radiation, and that's just for my enjoyment. I certainly would do that same risk to get a study that could find my cancer early and cure me. At Northern Arizona Radiology, we focus on you.